Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. Johns Hopkins Medicine, A Women's Journey strives to improve your well-being through health education. And we thank you for joining us this evening for this very special program. In the fall, A Women's Journey surveyed more than 25,000 consumers throughout the United States to identify the 3 issues that were of greatest concern to respondents. Tonight's speakers, Johns Hopkins doctors Lisa Maragakis, Anna Durbin, and Emily Brigham, will address the results, the importance of public health recommendations, the safety of vaccines, and lingering symptoms of COVID-19. And I'm so pleased to welcome our special guest, Kristen Welker, NBC News Chief White House Correspondent and co-anchor of Weekend Today on NBC, who will moderate a discussion with our experts. Following this panel discussion, you will have the opportunity to enter your questions in the Q&A section of your screen. I look forward to rejoining you at that time to address questions to our physicians. If we run out of time, the speakers have generously agreed to respond in writing to questions that are not answered this evening. If you're pre-registered for this program, you'll receive an email in the coming weeks with their responses. If you are streaming with us on social media or C-SPAN, please take a moment to register at hopkinsmedicine.org/A Women's Journey so that you receive the email questions with the answers. You also can download tonight's electronic program book, and I urge you to read the profile of tonight's participants and information about COVID-19, including articles that supplement this evening's discussion. Our webcast will conclude this evening at 9 p.m., and tomorrow you'll receive an email inviting you to complete a brief survey about this webcast. We also want to acknowledge the production assistance and collaborative efforts of Hopkins at Home and invite you to visit its website for courses and lectures. Now, I'm most pleased to introduce Dr. Paul B. Rothman, Dean of the Medical Faculty and CEO of Johns Hopkins Medicine. Dr. Rothman?
Thank you, Kelly. It's good to be with everyone again. It was about 1 year ago at the Women's Journey event in Naples, Florida, when the news broke that the first non-travel related case of coronavirus was diagnosed in the US. It has been quite a year. During this year, we have been on the front lines of the pandemic day in and day out. When I think about the Hopkins response to the pandemic, going back to thinking through from our website, which provides daily information, to the care we provide patients, what strikes me most is the dedication and sacrifice and bravery of everyone in the organization. People have been working tirelessly day and night, weekends, holidays to care for patients, to try to ensure that the public is really educated about truths about the virus and the pandemic, and to ensure that our community is healthy. And it has been something that has given us all great pride. We have been taking care of almost 6,000 patients during this pandemic. That's inpatients. Total, probably close to 20,000 we've been diagnosed with COVID. And we've performed over 350,000 COVID tests just within Hopkins Medicine. We've gone through 3 surges. One, as you know, in March, April, May last year. One a little bit in the summer, but really the past 2 months have been really hard with a lot of inpatients. Today, we're sort of coming down a little bit from our surge. But we still have over 200 patients in our hospitals today. And of the close to 6,000 patients that we've cared for in our hospitals, almost 600 have passed away. And so it really has been an all hands on undertaking. And it's just been very hard for our staff, and really their sacrifice is amazing. You're going to hear a lot today about some of the long-term effects of the virus. You're going to hear about the care we provide. You're going to hear about vaccines. And, one of the things that we've learned about this virus, it keeps throwing things at us. So the most recent thing is the new variants that are coming up. I think we're going to hear more about them. We know some of them have been in the United Kingdom, in Brazil, in South Africa. At Hopkins, we've been trying to find these variants, and we've been doing about 200 tests a week. We're probably going to end up starting to do about 1,000 tests a week, because we're starting to find variants in the populations around the Mid-Atlantic region, So far, just over the past 3 weeks or so, we have found 6 cases of the UK variant, and really within the last 10 days, 4 cases of the South African variant. So it is clearly here in the US, and it's something that we're monitoring as we go forward. Again, one of the big things you'll hear about is our vaccination programs. It has been, if you think about it, we're taking care of more patients than we have during any time of the pandemic. At the same time, trying to get vaccine to as many people as we can. According to both the National Academy of Medicine guidelines and the guidelines in the District of Columbia, Florida, and Maryland, we've started with our frontline healthcare workers. We're close to about 30,000 employees have been vaccinated. Almost half of them have gotten their second doses already. So we're off to a good start. I'm not seeing as bad reactions as we thought we might, but it's been a real challenge to get this going. And one of our major goals is to ensure that we provide equitable and equal access to all populations, especially vulnerable populations in some of the communities we serve, where people otherwise would not have access or not have the technology to have access. So we're setting up clinics, going into senior nursing facilities, helping nursing homes, everything we can to ensure that everyone has access to the vaccine. Well, now I'd like to turn to our panel. Over the pandemic, our speakers tonight, Drs. Maragakis, Durbin, and Brigham, have been doing fantastic work. I've got to hear from all of them, and I think you're going to be very, very impressed with just the outstanding work of these very talented physicians. But we're going to begin with our moderator today, and it's really a great pleasure to have Kristen Welker welcoming her to us here at Johns Hopkins Medicine. Kristen is a co-anchor of Weekend Today and the NBC News chief and White House correspondent, leading the network's coverage of every aspect of the Biden administration. We see her political reporting across all NBC News and MSNBC platforms, including Today, NBC Nightly News, and Meet the Press. Kristen joined Weekend Today as a co-anchor about a year ago. And in October, I'm sure you all remember when she moderated the final presidential debate and did just a great job. So since the onset of the pandemic, she's focused on covering the government's response, and she's very familiar with this terrain. So we're really thrilled to have Kristen with us today. Kristen, thanks and welcome.
Dean Rothman, thank you for that incredible introduction. I want to thank everyone at Johns Hopkins, A Woman's Journey. I'm so honored to be here tonight. And I just want to thank everyone at Johns Hopkins. You are literally on the front lines of this fight. All of the doctors, nurses, really the frontline workers who are making a difference as we address this crisis as a country. So thank you so much. I'm honored. I am looking forward to what I know is going to be a really important, critical conversation. But first, I do want to have everyone take a look at who our speakers are tonight.
We are at a pivotal junction in the fight against COVID-19. 1 year after community spread surfaced in the United States, vaccines have begun to emerge alongside new strains of COVID, resulting from mutations of the virus. Public health measures, including masking, social distancing, and hygiene, are crucial. While new treatments have reduced mortality and improved the care of those with the coronavirus known as SARS-CoV-2, we are seeing the lingering effects of this virus on those who survive. So much remains unknown about COVID-19 and its impact on humankind. Here to discuss what we have learned, why public health measures are essential at this time, the safety and effectiveness of vaccines, and enduring symptoms of COVID-19 are 3 Johns Hopkins experts. Epidemiologist and infectious disease specialist Lisa Maragakis, Immunologist Anna Durbin, and pulmonologist Emily Brigham.
That was just a great introduction to our speakers this evening. And again, I'm just so honored to be here. And as Dean Rothman said at the top of his remarks, I spend my day speaking to government officials about this crisis, SARS-CoV-2. But now we're getting to hear from medical experts about where we are as we take on this crisis. And Dr. Maragakis, I'd like to start with you and ask you to set the scene for us. Dean Rothman said that we have experienced 3 surges so far in this crisis. So where are we, and what is the status of the fight against COVID-19?
Thank you. I'm so happy to be here with everyone. And, we are now a year into this fight against this novel virus and this terrible pandemic. And as Dean Rothman said, we have had several surges. We thought in the spring that the surge was unimaginably big. But now we have found ourselves in the even larger surge. And we knew that this was likely to come during respiratory virus season, that we would see a resurgence of the virus. And indeed, it came to pass. And it was even bigger than the spring surge and much more widespread geographically throughout the United States and as we know, across the world. And so we've had over 103 million cases and 2.2 million deaths worldwide. And in the United States, over 26 million cases and over 440,000 deaths. We are starting to see some light at the end of the tunnel. We have vaccines on the horizon. We'll be talking about that this evening. In addition, in the United States, we are now starting to see decreases in the number of cases, thankfully. We think that the surge was really fueled after the December holidays and activities and gatherings indoors, as well as the colder, drier air. But we are starting to see lower case numbers and lower hospitalizations. And we hope that the mortality or the number of deaths will also follow. That's usually a lagging indicator, but we hope that that will happen as well. And January really was the worst month so far of the pandemic. Mm-hmm. And so we're hoping for brighter days ahead. As Dean Rothman said, we now face, however, variants that are emerging. And so I would say where we are is in a race with this virus to control transmission, stop the virus from having further opportunities to spread and mutate, and to get everyone vaccinated as soon as we can.
You hit on some of the really key top lines that we are going to be drilling down on. I want to let everyone weigh in on this, where you see this fight right now. Dr. Brigham, where do you think we are in this fight against COVID-19?
My sense is we're right in the thick of it right now. We're at an inflection point, and I've heard that used, that term used multiple times, but we are at one of the highest points of infection rates that we've seen throughout this pandemic right now, but we're also at a point where we have a vaccine and are moving forward. And we are recognizing that there are effects among survivors that require care. So we are at a point of urgency where we have to do everything at once.
And Dr. Durbin?
So I think what's really amazing is we had the first vaccines become licensed in mid-December, and we've already administered 32 million doses. It's been a bumpy road. I have to say we have a lot to learn logistically about deployment of not only these vaccines, but vaccines coming down the road. But I think we are learning. And really, as Dr. Maragakis said, in this race, what we want to do is get as many people vaccinated as quickly as possible to get us to the finish line. There's a lot of work to be done, but I think it's a tremendous accomplishment what's happened thus far.
Absolutely. The focus on enthusiasm for the vaccine all across the country cannot be overstated. Dr. Maragakis, before we delve more deeply into the vaccine and where we stand with the rollout of that and the challenges ahead as it relates to the vaccine, I do want to talk about some of the medicine, some of the therapeutics. used right now to address COVID-19. Remdesivir, dexamethasone, convalescent plasma are some of the top lines that we hear. And they've been developed, of course, to mitigate some of the effects. Are these all still under emergency use authorization? And are these still drugs that are routinely being used? Does everyone have access to them?
Great questions. It is one of the bright spots in this pandemic response that we have been able to improve our treatment of patients with COVID-19, improve outcomes, and keep a lot of patients out of the hospital and off of ventilators. So that has been a tremendous advance, and a lot of work went into that. Specifically for the drugs that you're asking about, remdesivir is now FDA approved, and dexamethasone is a steroid agent which is used off-label. So it was already available to us, and we use it for other conditions, and now it's been redeployed to treat patients with COVID-19. These two drugs, remdesivir, which is an antiviral agent, and dexamethasone, are frequently used together in hospitalized patients. The sooner that we can start them, the better. And there's certain criteria, of course, patients who are struggling with their oxygen levels and requiring oxygen. And studies are ongoing, and we've conducted at Johns Hopkins studies as well. And what we're finding is that remdesivir does seem to shorten the duration of the illness, and so helps patients recover more quickly. And the dexamethasone is given to kind of control the immune response, which sometimes can be really exuberant and cause even more damage than the virus itself. And then the convalescent plasma is also being studied and is under emergency use authorization still. And so that's serum that's taken from recovered individuals and can be given to try to help the immune system really fight the virus until your own immune system can kick in. And there are other things on the horizon and other things that are considered, but these are the mainstay right now.
And Dr. Brigham, let me bring you into this part of the conversation. Do you think these drugs are accessible enough to people in hospitals all across the country? And can they be used to help treat people who are dealing with lingering effects of COVID-19?
Sure. So I think I'm most positioned to answer the second half of that question for you.
Yeah.
So it's a great question, right? As we're thinking and searching for opportunities to try to treat the after effects of COVID-19. So when thinking about these individually, remdesivir is an antiviral, as Dr. Maragakis said. And so that's going to be theoretically most beneficial in the setting where there's an active viral infection. And so in the acute phase. Similarly, convalescent plasma, which is, has antibodies from patients who've recovered, should or could potentially, still being studied, help to stimulate the immune response against an active viral infection. Now, Decadron is interesting because Decadron is a steroid that's intended to reduce inflammation. So if we see that inflammation is what is driving the lingering symptoms of COVID-19 and that's being investigated, then I think there's a potential for this medication, but we're just not there yet. And it's quite likely that we're going to have to be looking at some different therapies entirely.
Do you think Dr. Maragakis will get there to the point that Dr. Brigham is making?
I do think that we will get there, and studies are ongoing, and drug development continues as well. And so, antiviral agents are one key piece of this. That if you think about a respiratory virus like influenza, for which we have antivirals that can blunt the infection and help individuals recover faster and have less symptoms. It would be wonderful if we had the ability to give an antiviral agent like that to people who are outpatients. They before they have to be hospitalized.
Yeah. There has been a lot of discussion about herd immunity. Dr. Maragakis, just to give us a reset here, what is it? What will it take to achieve it? Do you have a sense of when we might reach herd immunity as a country? Could it be by the fall if the vaccine rollout continues?
Right. So herd immunity it has been somewhat of a politicized term in recent months, but what it really refers to is the concept of getting immunity at a high enough level in a population so that a pathogen like the coronavirus cannot find its way from person to person because it keeps bumping into people who are immune. And fundamentally, that's what it means to get herd immunity. You can get there in one of two ways. Either by having natural infection, recovering and having immunity, or by getting a vaccine and having induced immunity from the vaccination. And of course, that latter kind of immunity is the one that we really value and want because we can save people from having the infection and the morbidity and mortality that goes with that. So what will it take to achieve it is really a rapid rollout of vaccine, and vaccine supply is a problem right now. And so there's many challenges there in terms of production and distribution and administration. And so these are enormous challenges, but many people are working on it right now. And I'm hopeful that with some of the new vaccines that are probably going to be available soon, in addition to the ones that we have, that we will be able to get to herd immunity, which we would say is around 75% of the population that's immune to the virus, hopefully by the late spring or summer, if not then, certainly by the fall.
And Dean Rothman talked about the various strains of this virus, which is, of course, getting so much attention right now, South Africa, Brazil, the UK. What do we know about these new strains? And it seems as though early indications are that it is potentially can be spread more quickly, but not necessarily more deadly. But of course, there's some variance among these different strains. What do we need to know about these different strains? And should we be anticipating that there are going to be more variations, Dr. Maragakis?
You know, this is unfortunately the natural history of what happens with viruses, particularly RNA viruses like this one. As they replicate or reproduce themselves during the course of an infection, small mistakes are made and mutations arise. The vast majority of those mutations don't result really in any drastic change to the virus or confer any advantage. But every now and then one will occur that strengthens the virus's ability to infect people, to be transmitted from person to person, or sometimes to affect the severity of illness. And that's what we've seen happen. So we have these different variants, one in the UK, one in South Africa, one in Brazil, another one in California. So all these different versions of the virus that have emerged and really kind of taken over in a matter of weeks to months to become the dominant strain. And why does that happen? Well, the mutation, and actually it's not just one mutation, but a whole group of mutations that confer an advantage for that version of the virus. What we know so far is that some of these have tighter binding to the receptor that allows the virus to enter our cells, that there's higher levels of virus in the upper airways, and that they're more easily transmitted from person to person. And studies are ongoing to see, as you say, whether they may also lead to more severe illness and death.
And Dr. Durbin, I'd like to bring you in on this point because we heard Dean Rothman talk about the fact that Hopkins is currently conducting genomic sequencing on these new strains. So help us to understand, do these current vaccines offer protection from these strains or other mutations? How should we think about that?
So I think what's important to know about these vaccines and particularly the mRNA vaccines and the virally vectored vaccines is that they show the body the genetic material of the virus spike protein, and that's made up of thousands of pieces of that spike protein. and how they're delivered, your body sees that protein and makes an immune response. And again, the important point to remember is that your body is recognizing thousands of pieces. And these mutations are a few pieces, a few parts of a very large protein. So there have been studies in the laboratory for both the Moderna vaccine and the Pfizer vaccine to see how well antibodies that the body makes using these vaccines, how well those antibodies bind to and activate the virus. And what we've seen is, although these antibodies may not neutralize quite as well to the South African strain in particular, they seem to work very well against the UK strain. They still bind and neutralize very well. So for the Moderna vaccine and the Pfizer vaccine, although we don't have specific efficacy data in people, that's going on now, particularly in the UK, where the Pfizer vaccine has been deployed. We do believe that those vaccines will induce good protection, particularly against severe disease, hospitalization, and death. And that's really where our public health impact is going to be, reducing those hospitalizations, reducing those deaths. And the immune response that's induced by these vaccines is really quite broad. There is good evidence from the Johnson & Johnson vaccine, which is an adenovirus vector vaccine, to show that it does prevent death and hospitalization from the South African strain. They just released some efficacy data in South Africa that although overall efficacy against COVID of any severity was lowered in South Africa, it was 100% protective against death and hospitalization, although there's still some few cases, but that's very encouraging.
So let me ask you a couple of questions that are going on in households all across the country right now, which is one, if you have the choice between Moderna and Pfizer, and once J&J is approved, should you take whatever is available or should you wait over the other? I mean, this is a question that my mom was asking me the other day.
If I could get up in big capital letters and scream, I would say, take whatever vaccine is available. That these vaccines, and I'm not going to go into the woods around what efficacy means, this, that, and the other thing, but it's important to remember that when we measure efficacy against disease, we're measuring a whole spectrum of disease. So in those efficacy counts are a runny nose with a positive PCR test. What we're really looking at, what the public health impact is protection against severe disease, hospitalization, and death. And all of these vaccines are highly, highly effective against those endpoints.
Here's another conversation that's going on inside homes all across the country. How can I trust these vaccines when they were developed so quickly? Why should people have confidence in these vaccines?
That's a great question. And there's a couple points that I want to make around that. One is that the mRNA vaccines, although Moderna and Pfizer are the first vaccines to be licensed using this technology, they've been studied for more than 10 years, mRNA vaccines for particularly cancer. So there's a lot of experience around these vaccines. The reason we were able to go from the first case of COVID being reported to having a vaccine in the arms of volunteers in less than 3 months is because of a tremendous cooperative effort between the government, the manufacturers, academia, and the removal of the financial risk around developing vaccines. And what do I mean by that? Well, normally we have very slow stages of vaccine development. It generally takes about 10 years to get a vaccine licensed, and that would be a fast track. And that's because we want to look at them in a small trial. We have to get all of the results. We have to make sure it's safe. We get all of the immunology results, which can take 1 to 2 years. Then we go into a little bit bigger trial, which can take 2 to 5 years. And then when the company is absolutely sure they have a winner, or they're pretty sure they have a winner, they make all of the investment in those trials, which are tens, 20 millions of dollars to do these trials. And then also tens of millions of dollars to manufacture and scale up. What the federal government did is they said, we are going to remove that financial risk, and we will guarantee that we will buy hundreds of millions of doses of these vaccines, even if they don't work. So we can put all of our safety studies sort of overlapping. So they have been studied. Each of these trials is enrolling at least 30,000 people in these studies. And at least in some studies, half of the people get vaccine, half of the people get placebo, and others, 2/3 of the people get vaccine and 1/3 get placebo. So we have safety data on, tens and tens of thousands of people. And now we have actual data from vaccination on millions of people. And the safety profile is really excellent.
And can all adults get vaccine? I know there are some concerns, particularly for women who are pregnant. Are there other adults who should be asking some questions if they have pre-existing conditions, for example?
That's a wonderful question. One of the reasons I'm really fascinated and a big proponent of the mRNA vaccines is because they induce an immune response like live vaccines without the safety risk of a live vaccine. They don't replicate in the body, they don't produce the illness in the body, but you get that very broad immune response. So unlike live vaccines, these vaccines can be given to people who are immunocompromised. They have been given to pregnant women. They can be given to older individuals that may be more frail. The one, what we call contraindication or reason not to give the vaccine to an adult is if they've had an severe allergic reaction to one of the vaccines or a component of the vaccine, which right now we've seen a few severe allergic reactions to these vaccines, and we think it's related to a component of the lipid envelope in which they're developed, something called PEG. But those studies are ongoing. But in general, even if you're, as I said, if you're on different medications, you can take these vaccines. We do know that if you're immunocompromised or immunosuppressed, you may not have quite a strong immune response, but there's not a safety problem with these vaccines. And I think that's really the key message.
And when I first started reporting on the development process of the vaccines, I think there were something like 19 potential vaccines in the pipeline. Are you still tracking other vaccines that are potentially in the pipeline that could make it to approval? And I would tack on to that question, how quickly do you think the J&J vaccine will get FDA approval?
That's a great question. J&J, we think, is probably within the next 2 to 3 weeks. I saw something from Dr. Fauci today saying he's expecting it very, very quickly. The AstraZeneca vaccine, we've done the Pfizer trial here at Hopkins. We're doing the AstraZeneca trial here at Hopkins. We're expecting hopefully an interim analysis of the AstraZeneca vaccine in the next 2 to 3 weeks. So hopefully we'll have emergency use authorization by late February, early March for that one. Novavax is on everybody's heels. That's a little bit of a different platform. It's what they call a nanoparticle, which is more just like a protein itself given with something to help the immune response. So I think we're going to have 5 of those vaccines available probably by March, which is really fantastic.
That's just incredible. 5. Wow. Yep. And I would assume that having that many vaccines available is what ultimately gets us to herd immunity, which Dr. Maragakis was talking about.
Absolutely. Absolutely. And you asked earlier, is one better than the other? I don't think from an individual perspective. One advantage from J&J's perspective is that it's single dose. And what does that mean? That means you essentially have twice as many doses you can give. Now, I think they're looking, based on their early data, they may require a booster dose after 6 months or so. But the data are encouraging that a single dose at least could get us through these humps of the pandemic and get us closer to herd immunity.
And do you anticipate that this will be like the flu vaccine or other vaccines where you need to do it on an annual or regular basis? How do we figure that out?
That's a great question. Again, that comes back to what breakthrough infections are we seeing and how severe are those infections? I don't think it's going to be like influenza. I don't think we're going to have to really make a completely new vaccine. I do think as time goes on, and I know that both Pfizer and Moderna and J&J are working on this now, is sort of tweaking their current vaccines to include some of the RNA of the new South African strain in particular. And they're talking about maybe giving a booster dose to get us over that. But we really won't know how much tweaking or changing of these vaccines we're going to need to do until we start seeing breakthrough infections. Again, if we're protecting people from severe illness and hospitalization, then we've really, gotten us out of, I think, the real public health crisis that this pandemic has caused worldwide.
And Dr. Maragakis and Dr. Brigham, let me just bring you both into this. As we continue to get vaccinated, of course, we've all been engaging in social distancing, people wearing masks. Dr. Brigham, do we still need to do that as we get increasingly vaccinated as a society?
Yes, very much so. Prevention
Didn't hesitate.
No hesitation there. Prevention is one of the most powerful tools that we have. And I think, and Dr. Durbin and Dr. Maragakis can comment on this as well, but I think there's still some questions about transmission, some questions about the new variants and so forth. And with this, and with things constantly shifting and changing, really, we just have to stay on our toes, and we have to do everything we can to keep ourselves and the people around us safe. And that means continuing with the hand hygiene, the masking, and the social distancing.
Dr. Maragakis?
Completely agree. And this is one of the misconceptions, I think, and everyone's excited, of course, because we're so tired of all of this. And the vaccines offer us the opportunity to see the end of the pandemic. But we really have to remember a few things. One is that even when you have the opportunity to get a vaccine, it takes time for your immune system to respond to that vaccine. And the vaccinations that are currently being administered require 2 doses. And so, unfortunately, we have seen quite a few people who are vaccinated and feel like they're protected before they really are. And so we can't rush into letting down our guard or feeling that these infection prevention measures can be relaxed too soon. And the other thing is that we don't yet really know. What we do know is that the vaccine prevents severe disease and death, but what we don't know yet is to what extent does it keep us from being able to pick up the virus and still transmit it to other people who haven't yet been vaccinated. And so for all of those reasons right now, we all just need to keep going with the masking, physical distancing, and hand hygiene until we really get to that herd immunity point and can back down on some of it.
And I would just add, I would just add one other wrinkle I would say is that, of course, we can't start vaccinating children younger than 16 yet. And that's a whole different population that can spread COVID.
Do you anticipate we will be able to, Dr. Durbin, at some point vaccinate children under 16? Is that the goal? Are we working towards that?
That is definitely the goal. And there are trials that have started and are being planned to evaluate these vaccines in children, with the thought that hopefully by the fall, we'll be able to start vaccinating children younger than 16.
Before we move on to our next topic, I think a big question on people's minds as it relates to masks, are we at a point where we should be wearing 2 masks? Should we be wearing a medical mask and then a cloth mask over it? Or is a good medical mask good enough? Who wants to weigh in on that one?
I can weigh in on
Dr. Maragakis, go ahead.
So there's been so much publicity around this concept, and I think that it's caused a lot of confusion. We saw some very prominent examples of individuals wearing 2 masks on top of each other. But it's really, it's not necessary to wear 2 masks, but what is important is to wear a mask that's tightly woven material and that has several layers, because that does offer more protection. And so if you have that kind of mask and you wear it consistently and you make sure that your nose and your mouth are both covered, and that there aren't large gaps around the sides, those are the things that are more important than stacking masks on top of each other.
Okay. I want to talk about some of the racial disparities that we have seen as it relates to COVID-19. And Dr. Brigham, let me have you start this section. Why are we seeing these? What are you seeing in terms of the severity of the illness, and also in terms of some of the lingering effects as it relates to different populations?
Sure. So I work in a clinic at Johns Hopkins, the post-COVID clinic called the PAC Clinic, and I work with a number of individuals. I'm the one here tonight, but I have so many colleagues and leaders who are right there with me, and we've seen a tremendous number of folks come through our clinic with lingering effects of COVID, but also post-hospitalization and post-ICU. And what's profound to us are the disproportionate representation in our clinic of underrepresented minorities. So we see, we have about 30% of our clinic are individuals who are Latinx, and that's compared to about 6 to 7% of the Baltimore City population. So I think that really speaks to a lot of these folks are recovering from critical illness, from the acute disease. And I think that speaks to the disproportionate burden on these populations in these communities. And it's not unique to Baltimore. We see this across the United States, that underrepresented minorities are disproportionately affected.
Dr. Maragakis, what are you seeing? Does this also extend not only to the severity of the illness, but to access to vaccines, trust in vaccines?
It does. It is really across the board. I think this pandemic has revealed so many of the vulnerabilities that were pre-existent before this virus came along. Access to care issues, pre-existing conditions in vulnerable populations, health literacy challenges. And as you said, vaccine hesitancy, unfortunately, is also disproportionate in some communities of color. And of course, we have vaccine hesitancy really across the nation, and it's grown exponentially in the last years. And in some cases, very deliberately targeted misinformation going to the African American community and some of the religious communities, really trying to propagate this idea and mistrust of vaccines. So we really do need to fight against that and provide accurate information and access to the vaccines.
Dr. Durbin, your take, is it about information access? Are there other ways that these disparities can be addressed?
Well, I think we've learned, as Dr. Maragakis said, we've learned a tremendous amount. I think there's several different factors that are playing into it. One, there has been historically poor access to healthcare in a lot of these populations. And to Dr. Brigham's point, when we had clinics in the community testing for COVID, overwhelmingly Latinx populations were testing positive, and that has to do with working conditions, multi-generational families where you have multiple people living in a house, people who can't work from home. They don't have the privilege of being able to work from home. They have to go out and they have to work every day, and they're exposed. Also, the fear, and this is not only with testing, but also something we're encountering as we try to do outreach for vaccination of different groups, fear that the government, ICE in particular, may come and arrest people if they're coming to get their vaccine. How do we reach people, to be vaccinated when they aren't part of the medical system? They don't have a provider. How do we reach them? How do we get to them? How do we help them sign up? There's a lot of different issues that I think COVID has exposed, not only in the inequities in healthcare, but just in our delivery system. And we noted a lot of this in our outreach for our clinical trials and trying to gain the trust of different populations who frankly didn't trust the government. And unfortunately, a lot of the vaccination efforts and testing efforts were highly politicized, which didn't help matters. I will say I was highly, highly encouraged. Before a vaccine was available, you had only about 30% of Americans saying they would take a vaccine. After we had the emergency use authorizations granted for both vaccines, we see that almost doubled now, which is encouraging. And I think as word gets out, we're going to have greater vaccine uptake. But we have to find a way to get those vaccines to people who are living on the margins, who don't have access to healthcare, and who can't, take time off to come in and get a vaccine.
Well, those numbers you cite are just remarkable. And if they continue to increase, that will obviously be so important. And part of it, you're right, is getting education to people and getting the word out about the vaccines and all of these questions answered. Dr. Brigham, let me turn to you and ask you about people who are recovering from COVID, but who still have lingering symptoms. What are you seeing, and what's your biggest concern? As we talked about at the top of this, there's still so much that's unknown, and that seems to be one of the really big mysteries.
It absolutely is. It remains. we feel like we've been doing this forever at this point, but it's hard to remember sometimes that the pandemic is about a year old, and there's still so much that we don't know, but we're trying to learn at a very fast pace. So we are seeing a variety of manifestations, a true spectrum of symptoms, and some of these were very much expected. And that's based in a foundation of literature describing the outcomes that we see in survivors of critical illness. So we have an unprecedented volume of patients who are moving through our intensive care units, moving through our hospitals with primarily respiratory disease, but a whole host of organ dysfunction in the setting of COVID-19. And we have studies we can look to that tell us how those patients might do. So there's something called PICS, post-ICU syndrome, but also post-hospital syndrome. And that describes a higher risk for impairments in mental health, impairments in cognition, and impairments in physical function post-hospitalization. And those are highly prevalent. And we know that those are associated with increased need for healthcare resources and even readmissions, which is particularly important at a time where we do not have hospital beds to spare in many instances. And so those things we expected, right? We expected those things. Some other things that we are seeing include a wide variety of symptoms: dyspnea, palpitations, fatigue. I mentioned cognitive deficits, but even in patients who weren't necessarily hospitalized, issues with memory and cognition and thinking. And those, are in patients who never had very severe illness or never required hospitalization and so forth, are really coming to light more and more. And we're seeing more patients who are coming to our clinic complaining of, this just isn't going away. I feel like my life has changed and I just continue to have these symptoms. And we have we do have some reference point for that. We have seen some of these symptoms, post-viral symptoms, in the past in the setting of prior epidemics. We had SARS-CoV-1, we had the Middle Eastern respiratory virus, MERS, but those were on a much, much smaller scale. And so we are now seeing this on a huge scale. So I think one of the questions we all have is whether there's anything unique to COVID-19 or whether this is truly just a post-viral illness and a post-incredible numbers of individuals recovering from critical care. And all of that is occurring on the background of a tremendous shift in society of what we do on a day-to-day basis. So we have individuals who are facing isolation, who are facing economic disadvantage at a scale that we have not seen, individuals who are lacking access to care. And then we have everybody's daily routines are completely changed. And so with that in and of itself is going to change the symptoms of our population on a day-to-day basis, but then add the post-viral syndromes and symptoms and so forth. And it's just a really large number of individuals are having ongoing symptoms.
And just to drill down on that, because you say something that stops me cold, which is that it's not just the patients who are in the ICU and who are intubated. You are seeing these lingering effects with people who had more mild symptoms as well. So have you determined why or who has lingering symptoms, how that, gets delineated?
No, we don't know yet. And in truth, the long hauler or the long COVID or the post-COVID syndrome, there are multiple names for it, hasn't been entirely defined. And in part because we see such a wide variation. But because of that, we don't know what the risk factors are. So if you have an outcome that's difficult to define, how do you then go back and find the individuals who are at highest risk? So we don't know. But I have seen, we do have patients who no pre-existing conditions, perfectly healthy prior to getting COVID-19, and then are left with these after effects. And we are working night and day at Johns Hopkins and institutions across the nation. This is more than a single institution problem. It's more than a single institution solution. We're all working very hard to try to figure out, one, why these things are happening, and two, what we can do to help.
And now that we're a year out, are you seeing some of these so-called long haulers? Are their symptoms receding at all, or are they just as persistent, or is it a myriad of different experiences?
All different experiences. Some people seem to feel better slowly. Some people seem to get better much faster. And then I have some individuals that I've cared for starting at the very beginning of the pandemic. We started our clinic very early back in April, who continue to have these ongoing symptoms.
What is the long-term prognosis for people who have had COVID-19? Because some people, and just broadly speaking, if you have COVID, if you recover, the thinking is you should be okay, you should be healthy. Ultimately, is that our understanding? Is that your understanding of how this virus behaves?
I think we hope. I think it's too soon to know, in truth. To really comment on that. But there are studies, a number of individuals are looking at studies out beyond a year, or planning to look out beyond a year at this point to see what the after effects are, even in individuals who are potentially asymptomatic.
And we think about other pandemics like the smallpox. I mean, will we get to a point where COVID has been all but eradicated? I should caveat that a bit.
You know, I would jump
Go ahead,
in.
Dr. Maragakis.
Yeah, let Dr. Maragakis take that one.
No, it's great.
What my colleagues say about it. But I would say we're unlikely to completely eradicate this coronavirus. What we know about respiratory viruses is that they tend to come back in a seasonal fashion. They do evolve and change over time. And we unfortunately missed the window with this virus, I think, to completely contain and eradicate it, which really was the case with SARS-CoV-1, its relative virus that happened in 2002. And that one had a much higher mortality rate. The patients got much sicker and were all in a hospital for the most part. And so it was a terrible scene, but it was easier because they were in the hospital to contain it. And unfortunately, many of the people who were infected died. And so it didn't really have the asymptomatic transmission that we're seeing with this virus. So I think it's unlikely that we'll be able to completely eradicate it. But if we have vaccines and we have antivirals, it can become something that's a little bit more of the normal landscape and not this kind of dread infection that we have right now.
And Dr. Durbin, I'm curious for your take on this.
So yes, I think one of the key difference also between smallpox and these coronaviruses is these coronaviruses live in species other than humans. Smallpox had no other place to live. So when we vaccinated everyone, it had nowhere to go. And I think also to Dr. Maragakis's point, I think we also have highlighted a great need from a public health perspective, and that is ongoing surveillance for these emerging pathogens. We started programs with SARS and with MERS and with avian influenza, but funding for that went away or declined. And not only the surveillance systems looking looking globally for new emerging pathogens, but also from the SARS outbreak, there were different groups that were established to actually look at platform technologies for vaccine development and therapeutic development to address these emerging pathogens. And CEPI was the major one. And from that, we got investment in mRNA technology. We got investment in adenovirus vector technologies. And we need to keep that investment going because unfortunately, SARS-CoV-2 is not the last emerging pathogen. We seem to be, it's sort of like Groundhog Day where we have one, it goes away, everybody relaxes. Then we have MERS, it goes away, everyone relaxes. We get Zika, it goes away. And now we're at COVID-19. We have to learn that continued investment in these public health measures is absolutely essential.
And you talk about the technology of all of this, Dr. Durbin, and I wonder, when God forbid we're dealing with another virus, have we developed the technology and the tools to be able to respond more quickly, to be able to develop a vaccine more quickly? Is that something that we can translate to the next battle that we may be facing?
I think if the next battle is a virus, I think so, because they're a little bit easier to fight. As we said, we just needed to make antibodies to the spike protein to, we think, fight COVID-19. Other pathogens might be more complicated. If it's a pathogen like human immunodeficiency virus or HIV, we have yet to have a vaccine for that. And I'm not sure that mRNA technology is going to get us there, although it may. But this is a very, very powerful technology that I think will be utilized in future vaccines very effectively.
You raise a point, and before I want to have you all kind of go around and give us some final thoughts, I have heard people say, why is it that we developed this so quickly and we're still working to develop a vaccine for HIV? So, simply put, why is that?
The reason is HIV actually gets into your cells and hides essentially within your own cells, and we can't see it. Your body can't see it, and it mutates very rapidly, so that when it does come out, you have antibodies, but those antibodies don't work against it. Whereas I will say SARS-CoV-2 is a much simpler virus. There's a spike protein. We can make antibodies that bind to that and prevent the virus from getting in. And that's why those antibodies work so effectively. With HIV, it actually hides its own entry point. So it only is seen very, very quickly as it gets into the cell. And then your body can't see it to fight it. And your own body's immune response actually helps destroy cells and makes you sick. And for that reason, it's a much more complicated virus than the RNA virus SARS-CoV-2 is.
We're talking about lessons learned, and as we approach the bottom of the hour, I'm wondering if you can all share with us the lessons that you think have been learned and how that might help this country, but the global community more broadly, be prepared the next time around. So Dr. Brigham, let me just start with you. What do you think the main lessons are that we have learned as it relates to science, as it relates to medicine, and as it relates to forming partnerships to tackle something as enormous as a pandemic, as a global pandemic?
So in the setting of a crisis, we can all do incredible things. And I think I have watched people just rise and shine in the setting of needs. And I think that crisis really brings us together too. We all partner to face a common foe. And that is true in COVID-19, that is true in other illnesses as well. I think we have opportunity here. We have an incredible amount of change that is occurring at a rapid pace. And with that comes the chance for us to refine systems, to optimize systems, and to change those that are not working. And really what we do now provides a blueprint for how we face crises in the future. And I think that speaks to what Dr. Durbin is saying and Dr. Maragakis is saying, is that this is not the last time that we will see an emerging virus or an emerging pathogen. But now is a time we have where we are all rallied together and we can really invest in perfecting systems to the best that we can so that we are handing these forward to the future and that these solutions exist.
Dr. Maragakis, what are your thoughts? What do you, and what a sort of wonderful way to wrap this up. I mean, it's just remarkable how much I think everyone has pulled together to address this crisis. And Dr. Maragakis, what do you think we've learned as a society?
Well, we've learned so much, and just to build on the comments that were just given so articulately and beautifully, collaborations and working together is what really has allowed us to respond to this crisis. But we know that we could do better. And preparedness, I think, we had some infrastructure that has really allowed us to do what we've been able to do. But public health infrastructure is not what it should be, particularly in our country and in many places around the world. And so we have to think of, obviously, pandemics are global events. And so those partnerships, I think, need to be global. But the infrastructure needs to be there for prevention and preparedness. The other thing that I would say, that takes investment, and it takes a multidisciplinary approach, because this is an infectious disease, but it has required operational details, experts in all different areas of medicine, of science, the logistics of vaccine distribution and administration. And I would just also point to the psychological aspect of responding to a pandemic. And we've talked this evening about the role of information and misinformation and resistance to some of the messages. So I think there's so many lessons that we will be learning for years to come. But when you look at the 1918 Spanish flu, for instance, they went through a lot of the same things, and at that time they didn't even know what a virus was. So there's some common threads there, and we need to learn these lessons so we can respond better in the future.
I'm so glad that you raised the issue of the psychological impact that it has had, particularly on our frontline workers. And so I'm just in awe of everyone who has been on the front lines of fighting this virus. And Dr. Durbin, would you pick up on that point? What have we learned, and how have people persisted in the medical community when you're really on the front lines and dealing with seeing and experiencing the toughest part of fighting this virus?
I want to start by saying something I hope we have learned, and that is, this pandemic has really, really highlighted the health inequities that are present in our cities and in our countries. And I hope that, when we have herd immunity and people start to get back to normal, that is not forgotten, that we really work to make sure that everybody has equal access to healthcare, to affordable healthcare, because I think a lot of really the tragedy of this pandemic is because people did not have access to healthcare before. Those are the people that we saw really impacted by the pandemic. And one of my concerns is, and this is something that we've been working within our communities in Baltimore, is to say we are not going to go away after this pandemic. We want to be here, and we want to be here for you, and we want to bring communities and ensure that people, whether or not they have insurance, whether or not they're documented, whatever, that there is equal, fair access to good quality health care. And that, I think, is a key lesson I'm hoping that we've learned from the pandemic, and that we will carry forward to make sure that we can, that people won't suffer unnecessarily.
Well, I think that's such a powerful way to conclude this part of this program. And before I send this conversation back to Kelly, I just want to thank you. I have learned so much. I hope everyone who's watching tonight has learned so much from all three of you, Dr. Maragakis, Dr. Durbin, and Dr. Brigham. Just remarkable. Thank you. Thank you. And I'm just in awe of all of the work that you are doing and all of the work at Johns Hopkins. So thank you. And Kelly, with that, let me send it back to you for questions.
Thank you very much, Kristen. We're so grateful and sincerely appreciate your commitment and expertise as our moderator this evening. We recognize the demands on your time, and we thank you for dedicating time to bring the news into each of our homes and advance our knowledge about COVID-19. Thank you so much.
Thank you so much. Thank you, Kelly, and everyone. And I was just honored to be here, and to everyone at Johns Hopkins. Thank you all.
Thank you.
Thank you.
Okay, so let's continue on, and we'll take some questions from our viewers. And please feel free, all three of you, to jump in whenever you want to add something to it, or you feel it's your question. So the first one is from Mary, and her question is it safe for those with disease like MS and Guillain-Barré syndrome to get the vaccine?
I'll take that one. How's that? So we get that question a lot. It is absolutely safe for people with multiple sclerosis or Guillain-Barré to take the vaccine. We have had several people who have called and asked specifically about both of those conditions, who have had histories of Guillain-Barré and been vaccinated. It is, it's absolutely safe. Even people who have had, for instance, Guillain-Barré after a flu vaccine. We've gained a lot of knowledge about Guillain-Barré, and we really think that vaccination is safe, and you should not hesitate to get a COVID-19 vaccine if you've had Guillain-Barré in the past or MS. It is safe.
Okay, thank you. I believe this is for Dr. Maragakis. Diane is asking, what has been learned from Israel, Brazil, and other countries' experiences and reinfections?
Specifically about reinfections, they seem to be relatively rare, and that we are thankful for that. Of course, this may change as we learn more about the variants, and if the variants mutate to the point that they can evade the antibodies that were created either after vaccination or after natural infection with the first version or the wild type version of the coronavirus, then we might start seeing more reinfections. But so far, they seem relatively rare. The other thing to know is that as the pandemic goes on, we're going to have more and more opportunities to learn how long the immune response lasts. And so right now, we know it lasts for 3 months. We have strong suspicion that it lasts for at least 6 months, and it could be longer. But we're going to learn more about that as time passes and as we do more surveillance for reinfection events.
Thank you, Dr. Maragakis. For Dr. Brigham, Sylvia would like to know, do you anticipate that new symptoms such as dementia may appear with time?
That's a great question. So I will say too early to know for sure, which is the theme of a lot of what I will say tonight. But given it's an anticipation question, I can tell you what we do know. So we have been very proactive in patients in our clinic. I'm a lung doctor, but proactive in taking a holistic approach. And given that we expected that patients would have heightened risk for cognitive dysfunction, mental health, and physical function deficits, we started screening for patients before they even got to our clinic for signs of depression, anxiety, and cognitive concerns or cognitive decline. And what we found in those screened in our highly selected population, those patients who had come to us seeking us out because of symptoms, that patients at about 3 months post-hospitalization, about 50% were demonstrating at least mild cognitive decline. Now that's a large number, right? That's a number of folks that are having difficulties with some of their functioning from a mental standpoint. Now, is that something that's going to get better? Is that something that's going to change over time? Or does this have longer term implications for the future and for their health, for their cognitive health moving on? We don't know. I think that those studies are ongoing and underway, but we may not know for some time.
Great. Thank you, Dr. Brigham. Dr. Durbin, this is from Donna. If you have had COVID, do you still need to get a vaccine?
Absolutely. Absolutely, we should get a vaccine. CDC is recommending, if possible, to wait about 3 months before you get your vaccine. And there's a couple of reasons for that. One, as Dr. Maragakis said, we're pretty sure that immunity post-infection lasts for at least 3 months. And two, for looking at sort of side effects from vaccination, we don't want to confuse lingering side effects from COVID, which Dr. Brigham has talked about, sort of the long-termers. We don't want to confuse that type of syndrome with side effects from the vaccine. So we want to space them out a little bit and make sure that people are fairly recovered symptomatically from COVID before they get the vaccine. The third reason is we know you get a good immune response from your infection, and we want to make sure that we wait long enough so that when we give a vaccine, you're going to get a really good immune response from that vaccine. Now, what's currently under consideration and under study is, do you really need 2 doses of vaccine if you've had COVID? That we don't know. That's a question that we're hoping we're going to be able to answer in the upcoming months or so. But that certainly, if you've had COVID, definitely get a vaccine.
Great, thank you. We have a question from Mina. Do you know where the virus resides in asymptomatic patients and why it doesn't cause symptoms?
Who wants to take that? I can start and then Lisa, I'm going to shoot it over to you. So, people have different responses to infections. So for instance, you can be infected, but you might not have a lot of virus that's replicating in your nose. And it can just be staying in your nose, and you don't get symptoms because it hasn't really invaded into your system, or your immune system handles it before you have symptoms. Or, a lot of people, I always say this, not only for COVID, but for other diseases I've studied, people say they don't have any symptoms, but they may have mild symptoms and they just don't think much about it. So they may have a runny nose for a day or so, and then it goes away. It's not enough to make anybody see a doctor. We do know from other studies that the more virus you have in your system, the more symptoms you have. So it's likely, that they don't have a lot of virus in their system. It can be they're wearing a mask, they're practicing social distancing, so they don't get a big exposure. And for that reason, they really don't develop a strong infection. And Lisa, I don't know if you want to comment on that as well.
No, I think that's a very good answer. And, I think we're learning more about it. But it's not unusual for pathogens sometimes to be present and asymptomatic. We know that can happen with influenza and other respiratory viruses. And as Dr. Durbin says, sometimes we ascribe very mild symptoms to just a headache or just a runny nose when it really is a symptom due to a virus.
Great. Thank you. Our next question is from Susan. Is there any value to test antibodies?
That's a great question. When the antibody test first became available, we had a lot of discussions about this, how to use it. One of the uses for it is really from a public health standpoint. Early in the pandemic, we used it to gauge really how many people had already had the infection. And it was very useful for that, and continues to be useful for that reason, because we know that some people don't even know that they had the infection. Maybe they were asymptomatic or had just mild symptoms. And so this has helped us to understand the extent of disease and how many people have been affected. For any given individual, many people are curious and may remember some symptoms or know that they were exposed at some point and want to find out. And an antibody test can be helpful in that situation as well.
Great. Thank you. I believe this question would be for Dr. Durbin. This is from Amy. Does the mRNA vaccine change your DNA?
The answer to that is no, it does not. And I heard a talk by Dr. Kizzmekia Corbett, who actually was the developer of the mRNA vaccine at the NIH. And she described the mRNA vaccines as sort of like a Snapchat message. So what happens is, and I thought that was great, although I don't use Snapchat, so I can only relate a little bit. But essentially what happens is the shot delivers the mRNA into your cell. Your cell's machinery then makes a protein out of that, and then the mRNA is degraded and goes away. And one of the reasons it has to be delivered in that fat lipid envelope is because mRNA is very easy to degrade. It is destroyed very, very easily. And it's only present there in the cells, we think, for hours to maybe a few days, and then it's completely disintegrated. It does not integrate into your DNA.
Great, thank you. We have a question from Caroline. Can you still transmit the disease to others after being vaccinated? And if so, if also the question is there a time limit, like 3 to 6 weeks later, 2 months later, if you've had the vaccine, can you still spread COVID?
So we need more data about this. But the answer right now is that we think it's possible. And so we're recommending to everyone, even if you've had the disease and you've recovered or you've been vaccinated, to continue the same types of precautions, wearing a mask and that physical distancing, because it is possible that individuals who are vaccinated or recovered could still pick up the virus and transmit it to others. And this is particularly important right now when the vast majority of the population are not yet vaccinated. They're still vulnerable to the disease.
Yeah, and just sort of to add on to that, I think just for understanding in general of how vaccines work, typically vaccines do not necessarily prevent infection, meaning that the virus can still get into you. What they do is they prevent disease. So it's sort of like taking someone who may have been, if they weren't vaccinated, would have become ill with COVID, to now somebody who's asymptomatic. So we think that the virus may still be able to get into your nose and replicate a little bit and therefore spread. But what the vaccine is doing, it's preventing you from ever knowing you had that infection. And so for that reason, as Dr. Maragakis said, we really need to still wear those masks, still practice social distancing, wash our hands, because we think that probably, although they'll reduce transmission, they won't eliminate transmission.
Okay, thank you. A question from Stacy. How is COVID affecting people in active cancer treatment? Good question.
I can maybe comment on that a little bit. So I work over in the oncology intensive care unit as one of the providers in my ICU time over there. And I will tell you, the providers over there haven't missed a beat in terms of getting patients in for the cancer care and the cancer treatments, at least from what I've seen. Now, I don't have a sense from a larger population health standpoint, but I do know that, delays in care are not ideal for a patient that has a time-sensitive disease. And so I think there's the potential with ongoing pandemic, if care systems are shut down, for infectious control procedures and so forth, for delays in cancer care. But I will say at Johns Hopkins, the folks over here are working hard to make sure those things continue despite it all.
Great, thank you. This question is from Jennifer. How long do you follow people who participate in the vaccine trials to learn about long-term reaction to the vaccines and the length of immunity?
That's a great question. All of these vaccine trials so far are for at least 2 years. So we will follow people for at least 2 years. And throughout that period of time, we're drawing blood to test for antibodies and other measures of disease to look for long-term safety. And then after rollout of these vaccines, and I think this is really important to know, if you do get a vaccine, if you have a side effect from that vaccine, it's important to let your healthcare provider know. There's safety reporting systems that we have in this country through the CDC and others to collect that information and to look for long-term safety signals as well. But in the trials, we're following people for at least 2 years.
Great, thank you.
I would just add to that, that if you have the opportunity to become vaccinated, please do enroll in the CDC's V-Safe program. It's a wonderful app. It's very easy to do, and it's on the CDC website, and it reminds you to report your symptoms. And so that's very valuable data that the CDC is collecting about how people feel, everything from very mild arm soreness to more serious side effects.
Great suggestion, thank you. Question from Mary Jo. Should I take aspirin or Advil before getting the vaccine? And then the second part of that is, why do you get a greater reaction after the second vaccine?
Okay, so we don't recommend taking aspirin, Tylenol, or Motrin before you get the vaccine, because we want to make sure that you get a really good response to the vaccine. What I usually tell people is, if you're getting a vaccine during the day, you can take a Tylenol before you go to bed at night and maybe a Tylenol the next morning. But you don't want to take it right around the time of the vaccine, because particularly a Motrin or an aspirin can affect your immune response to the vaccine. So we don't want to encourage you to take Motrin or aspirin or really any anti-inflammatory medication at the time or just before you get a vaccine. Before you go to bed is okay. And the reason you get a worse response with the second dose, and this is typically seen with the mRNA vaccines, it may be a little bit different from the AstraZeneca vaccine and Johnson & Johnson vaccines that are coming down the road. But with the mRNA vaccines, we think you get more reactogenicity or more side effects with the second dose, is because the first dose has done something we call priming. So it's sort of introduced itself to your body and to its immune system. And with that second dose, your body says, hey, I recognize that, and really gears up the immune response to give you, give some of the side effects that we're seeing, which are typically low-grade fever, perhaps muscle aches, some chills, the fatigue are common, but they're generally gone within 24 to 48 hours post-vaccination.
So Dr. Brigham, so would that mean, taking the second shot, they say it's how many days after the first shot? And should you be precise about that? If they say it's 20 days, or you can let us know what's the usual time limit that they give between the first and the second?
So with Pfizer, it's 21 days, and with Moderna, it's 28 days. And you don't need to be exactly precise, and CDC has come out with guidance around that and said it can be delayed. It can be delayed several days to a couple weeks post your first dose. It's not ideal to delay it too long, but we do understand that there can be some delays in terms of getting vaccines, or people have issues around getting the second dose. But it's not. We always recommend it's better to give it later than it is to give it earlier, just to get a better immune response.
Makes sense. Thank you. Good information.
Can I'm sorry to interrupt.
No, please go ahead.
I wanted to add one point about the anti-inflammatories. Just for patients who are taking anti-inflammatories for some other condition, I think in that case it's okay to continue your medications and get your vaccine.
That's an excellent point, Lisa. Thank you. That's a really excellent, important point.
Great. Thank you. Question from Dory. If you're exposed to someone with COVID, how long should I quarantine, and when do I need to be tested? That's pretty controversial because you're hearing a lot of different information about this.
Right. So if you've been exposed to someone who has COVID-19, the safest duration of quarantine is 14 days, is to do the full 14 days. And that's because if it really was an exposure, you were exposed to the virus, you can come down with symptoms or develop the virus yourself anytime really between day 2 and day 14. As we all have probably seen, the CDC has different options for shorter durations of quarantine, including 10 days or 7 days with a test at the end of the 7 days. But what people should know about that is that those are strategies to try to make it more palatable for people to quarantine for whatever reason, if they can't or are not willing or cannot do the full 14 days. But there is still a residual risk after you stop the quarantine between that and the end of the 14 days. And so the safest is to do the full 14 days. The other thing I'd like to say is that often the first instinct after being exposed is to run out and get a test, because you think, oh my gosh, I've been exposed to the disease and I need to test myself. And the problem with that is, as we've just discussed, you could develop the virus anytime in the next 14 days. So it can give you a false sense of reassurance if you get a negative test, especially if it's just like the next day or two. You haven't yet given it enough time. And that's why quarantine is so important.
Thank you. The next question is from Adam. Why is the US a small percentage of the world's population, but 30% of the deaths? That's probably you, Dr. Maragakis.
That is a very good question. And it's really a tragic question, right? We have just, as the statistics say, a disproportionate number of the deaths here, and it's tragic, and it is multifactorial. But I would say that unfortunately, despite all of the strengths that we have in this country. We really failed for a number of reasons to control the transmission, and have had uncontrolled transmission in multiple states and for a long period of time. That's led to this this tragedy, really, of the scale of the deaths. And so the lessons that we need to learn from this pandemic, we've talked about some of them this evening, about the health inequities. I think that we have some real soul searching to do about our preparedness infrastructure, our public health resources, and particularly about coordination between the federal and state level, and how we can do better next time.
Sure. Thank you. That's good advice and definitely so true. Here is a question from Melinda. Why are children less affected?
We don't have any pediatricians here.
I don't think we really know that. I mean, what we do know is that the elderly and people with comorbidities are more likely to get severely ill. And that has to do, I think, with just their complete sort of health picture. They're more vulnerable. They're less able to control the virus and control the side effects of the virus. And particularly the elderly, can become quite vulnerable to the disease. Younger people are less affected, less symptomatic, but can still develop severe disease, we know. And children also, don't have severe disease to the extent that we see in people 65 and older. And it's probably, they're resilient, they can get better, they have good lung function, they have good cardiac function, heart function. We really see the majority of the severe disease and deaths really, when you look at the numbers, I think something like 60% or more in those 65 and older. And it really is just a function of having heart disease on top of that, kidney disease, diabetes, and age that really predispose you to the more severe disease. But I do want to stress, that being said, we do see severe disease in children, and children can become ill. A lot of it we don't understand. We don't know if there's a genetic component to some people becoming more ill than others, particularly with the multisystem inflammatory syndrome that we've seen, and mostly in children, but also in some young adults, that we don't understand why some people are predisposed to that and why some children in particular get that and others don't.
Sure.
And young children are very vulnerable to influenza, for instance. So I think respiratory viruses differ in their predilection to cause severe disease in different age groups. And historically, certain strains of influenza have had the highest mortality in young adults in their 20s and 30s. That happened in the Spanish flu. So it's really a blessing, I think, in the midst of all this tragedy, that the children have not had the level of mortality.
Sure. Thank you. Question from Lisa. Do you need to wear a mask when you're outside, when you're biking, if you're alone, or you're in your car?
You don't have to wear a mask while you're by yourself. If you're by yourself in the car, or if you're outside by yourself, you can enjoy that time without your mask. That also applies in your house if you're by yourself, or only with your household members, or in your office with the door closed. But really, any time that you're around others, you need to wear a mask if they're not members of your own household. And one of the times, I want to really emphasize that one of the times that's the highest risk is when you remove your mask for eating and drinking and you're around others. And I know that there's massive economic devastation to the restaurant industry in our country, and it's a very contentious topic. But what we know is that when we gather and we're close to each other and we take off the mask and are eating and drinking, that is a high risk activity. And we see it whether it's in a restaurant or at a social gathering, even sometimes outside at social gatherings. or even in break rooms at your workplace.
Thank you. We have about a minute left before the top of the hour. So Susan has a question. Any value to test antibodies?
Antibodies help us know who had infection in the past. It's not a great way to diagnose disease of whether you have it right now. For that, you need to have the PCR test looking for the virus itself.
Well, thank you. This has been a most informative and enlightening evening. And thank you to all of our speakers, Doctors Lisa Maragakis, Anna Durbin, and Emily Brigham, for your insights and for your extraordinary efforts to lessen the burden and pain of COVID-19. If you have found tonight's discussion informative, please check out our website, hopkinsmedicine.org/A Women's Journey, to watch for announcements about future live stream programs, recording of tonight's and other programs, our podcasts, and women's health news, all brought to you by Johns Hopkins Medicine's A Women's Journey. Good night and be well.